Om Shri Manjataya Namaha. Good morning everyone and welcome to today's session on the topic radiology. Without further delay, I would like to call upon Dr. Mulidhar Sharma sir, Professor Emeritus, STMCA Udupi, to take over the session. Welcome to you, sir.
Okay, thank you. Uh, we were discussing about the fibrotic changes in the lung tissue, and we are seeing some examples of the fibrosis occurring in the lung tissue. Now, we will continue from that point of view. Now, in this X-ray, you can see that there is a evidence of reduced air entry, and it has a border which is corresponding to the middle superior and the middle lobe area, interlobe admission area. And if you just look at very roughly, the first outlook, it looks like a consolidation. But if you look through, you can make out that it's not a uniform consolidation. Instead, you can see thick band-like structures and some area where there is a clear air entry. And you can even see this bronchogram. Bronchogram means the evidence of the tubes, air tubes persisting over there. You can see the shadows of the air tubes, particularly the bronchiole and its branches can be seen. You can see these air shadows. And this is typical of a fibrosis accompanied or produced due to some obstructive pathology. A typical obstructive pathology occurring over the area that results in fibrosis. And this should not be confused. This need not be confused with the pneumonia. That's all the point. The important is, otherwise, if you just do not observe these finer points aspects, but look at only that ground glass-like appearance, it may be misunderstood as a fibrosis. Along with this, you also can see that the trachea is slightly deviated towards the other side, towards the same side of the lesion, particularly the bronchial division. Right bronchus is more deviated towards the same side, and the intercostal space also is reduced at the superior area, suggestive of a reduction of lung globe size. Those reduction of lung globe size and the shift of the trachea towards the same side confirms the fibrosis, and the cause for the fibrosis could be some obstructive pathology. The same X-ray, same patient's X-ray, in the lateral view, you can make out that the fibrosis is more towards the posterior surface, whereas on the anterior surface, you can still see the lung tissue as well. The posterior surface, particularly the superior second segment of the apex lobe, has become totally fibrous. This is one of the variations of fibrosis. Now, once the fibrosis occurs, how you look at it? The gross lung tissue, the gross normal lung tissue, and the fibrous lung tissue. The normal lung tissue, you'll have that spongy appearance, whereas a fibrous lung tissue that becomes a hard. Microscopic appearance also is the same thing. Now, in the fibrosis again, there could be some more variations. I have to refer to that issue. The fibrosis occurring due to inflammatory pathologies of a localized nature, as well as inflammatory pathology induced due to a hypersensitivity or allergic conditions. Now, in this X-ray, what you can see is that there are many bands, fibrous bands seen, but there is not much of a patchy lesion. These bands, of course, they are often can produce a confusion with the vascular markings. Along with this, now these are the bands which are almost vertical and they do not taper. They are suggestive of the fibrous bands. At the same time, there are many of the vascular bands, also vascular structures, bronchovesicular markings too, which are parallel and they are seen beyond their 2/3 limit. So there is a increased vascular marking as well as a few of the fibrous bands. Hilar shadows are, there are many multiple lymph nodes which are at different stages of calcification. Extensive calcification completed, some areas that signature-like appearance where the calcification is still under progress. So they cut, and there are some areas of spots of calcification in the lung tissue too. The lesion is bilateral, almost symmetrical. So this kind of a symmetrical bilateral pathology with a typical bands formation and along with the increased vascular markings is more characteristic of what we call as the allergic bronchitis, usually hypersensitivity due to exposures, pollutants, industrial disorders like now advanced silicosis you will have more of those features. We will come to that later. But early stages of an exposure to the pollution or any of the pollutants, rather, I am not saying only silicosis, it could be any of the pollutants, can result in the similar appearance. Often it also has a similarity to the interstitial lung disorder. I will come to that interstitial lung disorder immediately next. So show you some example. The same thing, like now in this X-ray also, if you look at the left to middle lobe area, there are some areas where the alveoli they seem to be dilated. The alveolar markings they are seeming to be slightly prominent. This is exactly what we see in case of the interstitial lung disorder. I have more examples of the interstitial lung disorders next. Now another of the X-ray where you have a similar feature but more extensive. Now here also in this X-ray also the hilar shadows are accentuated, vascular markings are increased, fibrous bands are seen in the lower lobe. The difference between the previous and the first this X-ray is in the previous X-ray the lesions were almost symmetrical, whereas in this X-ray the lesions are more towards the lower lobe, of course symmetrical, but more towards the lower lobe. The superior segments, upper lobes are almost saved. You do not find much of these areas of involvement there in the superior lobe. That suggests you are an early stage. Again, the pathology is the same. Otherwise, the findings are the same. The only difference is in the distribution of the lesion and the extent of the lesion. Now, one more of the example where the lesions are just a few of the bands, very few bands, and more of these mottling in the lung tissue. A mottling in the lung tissue is suggestive of recent venera. So the clinical symptoms of these patients would be like there would be always breathlessness, which is triggered by the presence of expection of expectoration or exposures, factors of exposures. Usually they develop sudden development of breathlessness, and often it also can result in clinical inflammatory signs like the fever and thick expectoration. Auscultatory findings are most of the times respiratory ronchi and shifting ronchi. Now that's another important feature. Inconsistent shifting ronchi is a characteristic feature. When I say shifting or inconsistent ronchi, in the sense you may not hear the ronchi in all breathing efforts. Certain breathing efforts, in some areas the ronchi could be heard, but if you repeat the auscultation again, you may not hear the ronchi at the same spot, it could be somewhere else. So that kind of a change is characteristic of the allergic bronchitis. Now, a persistent allergic bronchitis, and it can result in what we call as the interstitial lung disorder. Now, interstitial lung disorder is just an extension of a multiple form of the pathology, where again it's a fibrosis, but the fibrosis occurs in the collagen tissues, resulting in a gradual constriction of the lung tissue. Lung tissue becomes inelastic. The elasticity of the lung tissue is reduced, and it's a very slowly progressive pathology. Causes could be many. It's often a result of these irritants like allergic conditions, pollutants, or it could be even a consequence of infective pathologies like even bronchitis also can later in due course of time can result in interstitial lung disorder, or interstitial lung disorder also can be produced due to other systemic disorders. Among the other systemic disorders, autoimmune disorders like rheumatoid pathology, multiple sclerosis, and so on, or scleroderma. These are all the conditions which can precipitate the interstitial lung disorder. Now, what we see is again, you can see the similar fibrous band-like structures, but the bands do not have a characteristic pattern. Instead, the bands they are somewhat irregular and they do not form a patchy lesion even. It looks like the borders of the interstitial lung tissues have become enhanced. To highlight the same, I have just separated this segment and magnified the same. This X-rays only, this area is magnified and you can see those features better. The alveolar pattern, they seem to be more prominent, but and the size of the alveoli are not uniform, and there are many areas where there is some mottling, some amount of mottling, and air entry is not uniform. This is the typical feature of a well-developed, well-established interstitial lung disorder. Another example of the same. still more advanced interstitial lung disorder. In this X-ray, it's quite obvious, like you can see the total expansion of the lung tissue is reduced in the shape of the intercostal spaces. It's quite typical, like it seems to be converging, like, and of course, in this X-ray there is a technical error. Technical error is a scapula is not fully retracted anyway. But beyond that, if you look at the lung tissue, you can see this dense mottling along with that thicker fibrous bands all mixed together. This kind of picture is a advanced interstitial lung disorder, which again doesn't mean a single diagnosis. Cause for the interstitial lung disorder has to be evaluated. Interstitial lung disorder also can present in a fashion where it may not be uniformly involved in the lung tissue. Some areas may be more involved, as in this X-ray. In this X-ray, you can see this interstitial phenomena in the right lower lobe more prominently than on the left side. Of course, left side also you can see the lesions, but left side has still some more amount of the normal lung tissue. The left apex area, the lung tissue seems to be normal, but in the right lower lobe, middle lobe area, the interstitial phenomena changes are quite prominent. Though generally, the interstitial lung disorders are generalized. And quite another important issue with the interstitial lung disorder is in the initial stages of interstitial lung disorder, you may not be able to make out anything with the X-rays. So initially, in the early stage, ILD cannot be diagnosed with the plain X-ray, and in that case, it's only the CT scan, particularly high-resolution CT scan. Patient may not have any other symptom except reduced exercise tolerance. Those who develop breathlessness on climbing the second floor during rounds, they are better advised to have the CT scan study, particularly HRCT, high resolution CT scan study. It could be a possible interstitial lung disorder which may not be identified by the plain X-ray. So that's the important issue. Now, this series of the HRCT images, they highlight the same issue. The interstitial lung disorders which are in the different stages. The first two sets are, these four images are HRCT, high resolution. These three images are of the moderate, that usual CT images. Now, the high resolution images in the early stage, it can show you the same phenomena where the lung tissue has many fibrous bands-like structures seen, and this is better seen almost in the same stage, like same duration. The moderate usual CT image is done, and in the CT images, those changes are not that conspicuously visible. In this condition, if you take the plain X-ray, probably the plain X-ray may be showing normal. Now, after a few months of the progression of the disease, a high resolution CT was repeated, and repetition of the high resolution CT shows that there are the same fibrous bands formation and they are better visible, whereas at the same time, simultaneous, a plain CT, it may not show the same features. There is a difference in the intensity of the features seen. Of course, if at all a plain X-ray was done at that period, probably the changes may be seen, but the changes might not be as conspicuous as in the case of a CT image. This is another example of the same HRCT of two patients, another two sets of the patient. These two again another set of the patient. Early stage and later advanced stage. A CT image at this advanced stage, moderate CT images. Now comparatively, the X-ray image, plain X-ray image might not show you the same intensity. So severity of this interstitial lung disorder can be better assessed by HRCT, high resolution CT as such. Or, of course, the clinical features should be very characteristic. Clinical features should be of reduced exercise tolerance. Now, a smoking and interstitial lung disorder. This also is, these are the sets of four different patients, not of the same patient, where the smoking can produce the ILD, and the characteristic differences are, in the first image, you can see that extensive fibrosis with a few of these emphysematous areas. areas where the air is loculated. In this second image, lower image, you can see many big vacuole-like structures. Some of these alveoli, they are fully dilated and they are quite big as bubble of air is formed, and there could be an increased density of the fibrous tissue, which is just like a uniform distribution. The lung has become inelastic. In the other third X-ray, that is again the difference is the fibrous tissue is somewhat scattered. The density of the lung tissue has become increased, but you may not see these alveolar emphysema. In the fourth, this image is only that the lung tissue has become totally inelastic. Virtually, you don't find an emphysema. The purpose of showing all these four images are the impaired in interstitial lung disorder precipitated due to smoking can be of heterogeneous type. Different types can occur. It may not be uniform. So it may not be possible to conclude whether it is the smoking being the cause for that or not only by the radiological image. Instead, you will have to take a clinical history and then you may suggest that whether it is due to the smoking or not. Now, when we have discussed about pneumonia, fibrosis, and ILD, then there is a relevance of the COVID lung disease, which is the craze of the day. Now, COVID lung disease, as we know, it's not that every patient of COVID will have a lung disease. Only a few percentage, low percentage of the patient would have the lung involvement, and the evidences of the lung involvement are better identified by X-ray images. And produces a pneumonia, but unlike that of the usual lobar pneumonia, this pneumonia would be a patchy as ground glass, patchy areas of pneumonia produced, and they may not be limited to anatomical segments or anatomical lobes. And that kind of the patchy lesions seen in the beginning are the characteristic feature. But later, as the condition advances, it may result in the fibrosis, fibrous bands can occur, as well as interstitial lung changes also can occur in due course of time. In this X-ray, you can see a patchy lesion, ground glass like patchy lesion, where the shape is irregular. Unlike that of our plain this usual conventional pneumonia, you don't find that limitation to the anatomical areas. And then some areas where you'll see that typical features of the fibrous bands formation. I think this you can make out. And along with that, the changes in the interstitial area, the lung tissue, particularly right lower lobe and middle lobe, has shown the changes there. And this is typical of the COVID lung disorder or COVID pneumonitis. Again, to highlight the same issue, a COVID and non-COVID pneumonia, I have put the two X-rays to compare. In a typical non-COVID pneumonia, there is a uniform ground glass-like consolidation involving an anatomic area like a lobe. In this X-ray, you can see the superior and the middle lobes involved, whereas a corresponding, now it's not that same, corresponding pneumonitis occurring due to the COVID pathology, you can find the ground glass appearance, but the ground glass appearance need not be limited by the anatomical area. You will find patchy lesions, and these patchy lesions differentiated from the COVID pneumonia. And the COVID pneumonia, as it gets evolved, like the COVID pathology, the course of the pathology also is rapid, and these changes, pneumonitis and the fibrosis, as well as the interstitial changes, they tend to occur at a rapid course in case of the COVID disorder. Now, these are the sequence of X-rays of the same patient, day 5, day 7, 8, 10, 11, 13, and 18. By 18th day, you have all the phenomena in the lung. This patient is in ICU, and hence you will have these extra tubes and so on. There is an extensive patchy lesions and consolidation produced over there, and then of course the interstitial phenomena also has occurred, and fibrosis also. So you have all the three phenomena. To understand that COVID lesion, you have to have the clear-cut picture of all the three phenomena: the fibrosis occurring, the pneumonitis or the inflammatory changes occurring, and then the interstitial lung changes which can occur in due course of time. So that's the typical course. And another characteristic is a rapid course of the patients as such. So this shows, like in day 5, virtually you don't find very huge lesions. Plain X-ray seems to be somewhat within normal limits, or except a few of these peripheral opacities, you don't find significant abnormality. By day 7, there is a significant consolidation seen in one segment area, in the left lobe, upper lobe, and middle lobe area. Day 8, there is a lesion on both the sides. Both the sides are involved. That's how the scoring would increase, and those sides would be showing evidences of the exudates, extensive exudates lesions are extensive. Again, day 7, the same extension further. Sorry, day 11, it shows the same extension. 13, there is more of the pneumonia. The consolidation has become extensive, and even there is an evidence of the lymph node involvement. The mediastinal shadows also have become wider. And of course, day 18, almost both the lungs are consolidated. Virtually, there is very little air entry as such. This is how it occurs. Now, that COVID scoring, the RAD scores, RAD score is a reporting and data based scoring. There are many scoring methods followed, but the more popular method is the RAD scores or CD RAD scores, which are the more popular method of scoring of COVID disease. And the method of scoring is only that method. By dividing these lung tissue into anatomical segments, these segments like 1, 2, 3, 4, 5, 6, right? Just simple. It's not simply anatomical lobes. See, that's the issue. Instead, the whole thoracic area is divided into 3 segments: apex, the lower, and the middle. And based upon the number of lesions and based upon the percentage of involvement, like if it is 0%, 25%, 25 to 50, this is how the scoring done, and the RAT score is done as a score 1, 2, 3, 4. Of course, there are many other scoring methods, PSS score methods. I think that's not necessary. But the important is that each area, the number of lesions have to be counted, and then you'll have to give a score of 0 to 4 each of the scale area, so that you can have total 24 scores of the RATs. That's the popular one. Again, to give the examples, lung RAT scores. In this X-ray, you can see there are 4 X-rays of different scorings as such. Now I have put in more of these because COVID is still persisting and still an area of interest, so that's why more stress is given on that part. In this X-ray, you can see the lesions in the middle lobe, and in the middle lobe, almost more than 30% of the middle lobe has been involved, and in the lower lobe, almost 70% of the area is involved in right middle lobe and lower lobes. Left middle lobe, you can see only the peripheral lesions, some 10 to 25% is involved. So the total score in this case would be almost, you will give 3 scores, 4 scores, 3 and 4, 2 and 2. So 4 plus 3 plus 4. So you may have a score of 11, RAT score 11 in this X-ray. Second X-ray, the RAT score, in this case, we may give 1 or 2 scores to these lesions in the left lobe, whereas in the right lobe, you can give 2 scores. So 2 plus 2, 4, 4 plus 2, 6 would be the score as such. Whereas in this X-ray, the involvement is quite significant. Air entry is markedly lesser in the right middle lobe. So you may give 3 and then 2, 3 to 5, and then 2 plus 2 could be 9 or maybe 8 scores. That's how the scoring is done. So method of scoring is simply by studying the extent of involvement and the area as such. That's how the scoring is done. Now one more example of the evolution of the COVID pneumonia, where you may have some more of the complications. These are not of the same patient. Images then taken at different durations, day 3, 5, 6, 8, 10, of different patients with having different complications. Usually in the initial stages, it's only the patchy lesions seen. Later, that patchy lesions, they develop the interstitial phenomena, the patches with the fibrosis also. Rarely, they may even produce a pneumothorax. There is an air present in the pleura in this patient, which can result due to the perforation, one of the complications which can occur, not a usual phenomenon. So a presence of the air in the pleural space. Of course, pneumothorax as such and its details we will discuss in the due course of time. But this is just casually because we are discussing about COVID and the COVID complications. Just from that point of view, I refer this also could be one of the possible complications, or it could be like the later it can result in the extension of the lesions. The extension of the lesions could be in the vertical manner or it could be in the horizontal manner where both could be involved. In this case, it's a vertical progression, lower lobe involved and then the middle and then extension. Or in the other X-ray, it could be the horizontal in the sense initially it's the right side and then the left side. So that's how it can occur, and it can even result in a pleural effusion. So involvement of the pleura, either of pneumothorax or effusion, also could be the other complications which can occur. Once you these extrapulmonary complications are there, then the score would be 6 additional. Another COVID score would be RAT score would be 6. So these scores being based upon the clean X-ray is one phenomenon, and they are not supposed to be very accurate. So now the standard for scoring COVID is HRCT scoring. HRCT scoring is again the same basic issues where depending upon the amount of the lesions, when there are no lesions, it is scored as 0, and then when there are some suspected patchy lesions in the CT, this is HRCT images, sequence of the HRCT images. Score 1 when there are some scattered shadows, when there are advanced established shadows, patchy shadows, and they are seen in one localized area, as you see in this case on the right side. Then that's score 2 when the lesions have resulted in a ground glass like appearance, consolidation, and then there is an even a moderate amount of the fibrous lesions developing. So these are examples of the score 3 when there is a consolidation involving the segment, or a consolidation, again a established consolidation with fibrous changes. In the image 3, you can see that fibrous changes seen in the JRCT. These are all suggestive of a later advancement, further advancement of the lesion. So score 3 is given, and when the same has become involving more than 25% of the lung, one lobe, then the score 4 is given. So this is a core-rad score of HRCT. HRCT core-rad score and lung-rad score, they are slightly different. So where the lesions are extensive, involvement of more than 25% of the lobe is seen, then the score 4, and score 5 is then when there are bilateral lesions on both the sides, and then there is involvement of the pleura also, very extrapleural area also, then there could be score 5 or even score 6 also is there conventionally. So this is about the method of scoring for the COVID-19, which suggests about the same issues. So that's about the fibrosis and consolidation phenomena. The next part which we discuss would be atelectasis. Now, atelectasis word means there is an obstruction to the air passage, and hence the alveoli has become dilated. Ectasis means dilated, a dilated alveoli. Now, we use the word atelectasis, emphysema, and so on. There should not be any confusion about that. Emphysema is a locked air produced due to a dilatation of one bronchial division, either a bronchial division or a bronchiolar division. Atelectasis is when there is a dilatation of an alveoli or a group of alveoli. So, to understand that phenomenon, the alveoli remain expanded because there is a continuous flow of the air. The normal, there is constriction and the expansion. When there is a continuous flow of the air in and out, then the alveoli they expand and constrict and they maintain their configuration. Now, when the airflow to the alveoli are blocked, now if there is a complete blockage, quite obviously the alveoli get collapsed and there will be, you will not be able to see the alveoli. But if there is a partial blockage and hence the air doesn't really get exchanged, the air gets locked in the alveoli, air may flow in, but it may not flow back, that it may not flow out to the same extent. There is a possibility, and this occurs due to a partial blockage. The air remains locked in the alveoli, and the alveoli may become dilated. Though the alveoli become dilated, the total expansion of the lung tissue, in total, the whole lung tissue, it cannot expand to the same extent. So there is a controversial issue. The whole lung tissue may get reduced in size, but within the alveoli may get dilated. And this phenomenon is atelectasis. Atelectasis is suggestive of an obstruction in the microstructures, the finer tubules of the alveoli, and hence the alveoli get dilated due to the locked in air. At the same time, because the total lung compliance is reduced, the elasticity of the lung tissue is reduced, the lung tissue size becomes reduced. Now, and the conclusion of that would be that there is an obstruction at the micro level. It doesn't suggest any single disease entity. It could be due to multiple diseases. It could be due to tumors. It could be due to some foreign body. It could be due to tuberculosis. It could be due to a consequence of any other inflammatory pathology. An interstitial lung disorder also is very akin to, very close to the atelectasis. It can result in atelectasis. So, atelectasis is not a clinical diagnosis. It's a radiological confirmation of the pathology, and that pathology always has to be interpreted with the clinical evidences. So, conclude which is the disease, it has to be based upon the clinical evidences. Now, in this X-ray, when you read this X-ray, you can see that there is a very obvious reduced air entry to the left side, and the intercostal space on the left side is lesser than that of the right side. If you look at the position of the trachea is more shifted towards the left side. You can see that trachea is slightly curved towards the left side. There is a shift towards that. Of course, the cardiac shadows also, though the very not conspicuous, but there is a tendency for the cardiac shadow to shift to the left side, and over the left lung lobe throughout, the air entry is reduced. Obviously, there is a density which is of not uniform nature. Within that dense area, you can find a air containing shadow. I think you are able to make out this air containing shadow. I hope you are able to make out that. A irregular bubble-like structure, a big one, and then there is another smaller ones, a few of them, another moderate sized area. Now, this kind of a phenomena where the air is locked in is suggestive of atelectasis. So, atelectasis is a disease or a condition where the lung tissue is not able to expand, and alveoli get dilated, and air locked in would be the feature. Clinical signs of atelectasis are the breath sounds are diminished, the inspiration intensity of the expiration would be normal, duration of the expiration would be much more prolonged, and the gap between the inspiration and expiratory sounds will be almost absent, lesser. Air doesn't enter into the alveoli, and that typical vesicular breathing sound would not be heard. So air just reaches up to the area, and then the air flows back. And the time gap for that air to flow back would be lesser because it doesn't enter into the alveoli. So the typical features of the breathing, which we always say as bronchial breathing, and in a very standard bronchial breathing, the intensity of the expiration would be increased. But in this case, intensity of the expiration may not increase, but the duration may be increased. Atelectasis, because the air flows back slowly, the duration is enhanced. The intensity of the inspiration becomes slightly diminished. In total, intensity of the air breath sounds on the affected side would be lesser than that of the normal side. So that's the typical clinical evidences of the atelectasis. Causes, as I said, it has to be evaluated based upon the further history. It could be due to any of the other conditions that atelectasis can occur. Only once the atelectasis has occurred, all that would be, the evidence would be like there is a irreversible change. The lung tissue would be having a irreversible pathology, and the air is locked in. That's all the conclusion which you can draw. Now, another example of the same. Now, in this X-ray, again, you find that the air shadow on the right side is significantly lesser. Trachea is shifted to the right side. Almost it looks like a ground glass appearance. But if you look at carefully, there is an area of increased density of the air in the right middle lobe. I think you are able to make out after the cursor moves over. I hope you are able to make out that area of increased air density in this area. Similarly, some more air shadows seen over the periphery. This also is a feature of the atelectasis here. Maybe there could be an obstructive pathology, a severe gross obstructive pathology in the bronchial area, and often this kind of bronchial obstructions, which are of slowly progressive nature. Now, it may not be a foreign body. In a atelectasis produced due to the obstruction, usually, of course, exceptions could be there, but usually, when there is an atelectasis produced due to obstruction, we suspect some tumor pathology than really a foreign body. The reason is simple. In case of a foreign body, the obstruction will be sudden and can be nearly complete, and hence there would be a collapse, total collapse of the lung. When there is a partial collapse, it's not a total collapse, and air gets locked in. Often the cause could be a slow growing, a gradually growing phenomena, and hence usually we suspect tumor pathologies. And the next level of the investigation will be bronchoscopy. Bronchoscopy will confirm the lesion. So it may not be possible to make out the exact cause for the atelectasis with the plain X-ray alone. Of course, a CT is next level of the satellite. A CT also can give you some clue about the real cause for the atelectasis. Now, some more of the examples. Of course, the quality of this X-ray is not that good. It's a slightly overexposed X-ray. But one obvious feature which you see is there is a gross shift of the mediastinum. Instead of the trachea, it's the mediastinum which is shifted to the left side, and there is absence of the air shadows, a typical absence of the air shadows. And within that, the hazy area, if you keenly observe, you can see this bronchogram, the tube-like structures here. In the other area, of course, the quality of the image as it is copied, it's not proper, but because there is a consolidation-like feature, along with the reduction of the lung lobe size, the evidence of the reduction of lung lobe size is the mediastinum is shifted. The hair shadows are shifted to the left side. Virtually, you don't see these hair shadows on the right side. That's a typical of the atelectasis. In addition to this, there is another of the feature on the right lower lobe. You can see these fibrous bands seen. Multiple fibrous bands are seen, and the lung tissue, it seems to be expanding even more over the diaphragm. Now, this is typical of the emphysema. We will have more of that evidence discussion about the emphysema in the next classes. But this is one of the abnormality. The borders of the lung tissue seen are not sharp, and so you can see the diaphragm, dome of the diaphragm, and the air shadows are seen penetrating through that, or maybe overlapping over that shadow of the dome of the diaphragm, and that border is slightly irregular. This is what we call as the emphysema. More of the emphysema we will discuss in due course of time. Now, atelectasis also can be accompanied or maybe produced due to other causes. Now, atelectasis can also be resulted due to a bronchopleural fistula. A bronchopleural fistula is if there is a patient has a pleural effusion, or then the drainage has occurred, and due to the chest tubes which we usually insert, like during the drainage we insert the chest tube, and that chest tube insertion will increase the positive pressure in the pleura. That results in the collapse of the lung tissue, but it may not be a total collapse, and there again there can be atelectasis. Now, this is one of such evidences. Patient had a pleural effusion, along with the has some lesions over the superior segment, which could be like a dense mass, and there is a partial atelectasis seen in the right middle lobe, the middle lobe area. This is produced due to the tumor. There is a shift of the trachea towards the right side. Pleural effusion is marginal. Now, in another patient, it's not of the same patient, a chest tube was inserted, and maybe it could be as a result of the chest tube being inserted, the lung lobe has become collapsed, the right lower lobe and the middle lobe has become collapsed. All the mediastinum has been shifted to the left side. Air shadows in the left side is quite huge. The left expansion is quite huge compared to the right. The left expansion is quite huge. This could be even due to the compensatory phenomena. In the second image, the compensatory phenomena is seen. Virtually, you don't see any vesicular pattern it looks like all the difference between the air shadows and the lung and outside is virtually negligible. This also could be an error of exposure. So the exposure had to be modified in this case. So it's a relatively overexposed X-ray. But still, the important here from our point of view is what you see in the right side. Trachea as well as the mediastinum is shifted to the right side, and then you find these air shadows in the collapsed lung tissue. The presence of the air shadows in the collapsed lung tissue suggests of the atelectasis. Here you have two images. The first image is due to an endogenous obstructive pathology, possibly maybe a tumor, which involves the right apex and apex lobe area. In the second, it is due to the chest tube insertion and then the pleural shift of the trachea towards the shift of the mediastinum towards the same side, that atelectasis occur. Atelectasis also can occur in the lobar conditions, lobar involvement, and it may not be limited to one area. Now in this X-ray, what you find is there is a reduced air entry to the left middle lobe area, and that fibrous bands. So you may consider this as only the fibrous bands, and within this fibrous band area, you can find these dilatation. In the previous example of the fibrosis also, we have referred to the same similar issue. When there is a fibrous band occurs, it also can result in a small atelectasis changes, minor atelectasis changes, which is confirmed by the lateral view X-ray. In the lateral view X-ray, you can see this area of fibrosis and then the presence of the air shadows within. So it's a common phenomenon. Atelectasis occurring as a result of the fibrosis is a common phenomenon. All that what we could easily, and the lung tissue would not never be a normal compliance. So person would have always a reduced exercise tolerance will be always reduced in that patients as such. Now, technically, the terms used for these atelectasis or fibrosis also are S curve and bowing signs are often used, but I think that's not a very significant issue. But still, because we are discussing academically, we refer to that part also. When there is a collapse of the lung lobe due to the atelectasis, the borders of the atelectatic area may be curved, and that curvature either could have a double curvature, which we call as the S curve sign, or it could be just a single convex curvature, which is called as a bow signs. So that's not a very huge issue. In these X-rays, in the first X-ray, you can make out that there is a shift of the trachea towards right side, and then there is a air shadow, irregular air shadow, collapse. Of course, similar features as you have seen, and then the important is, the only difference is the borders of that atelectatic area is having that double curvature appearance, something like a S curve. Whereas in the other lateral view X-ray, it's not of the same patient. In the other lateral view X-ray, again you can see that atelectatic area in the apex area, and then there is an air shadow. Border of that is having a single curve, and that's called as a bowing sign. Now I think that bow or S curve, that's not a very significant issue. It could be of any shape. You may give any name, any letter as such, but that's about what you find in the textbooks. So from the academical point of view, I have referred to that. Now, how you see an atelectatic lung tissue in a gross, the lung tissue will be constricted, but if you cut that area, you'll find some empty hollow area over there. That's the atelectasis asset. The increased density of the border area and reduced air entry and air locked in. That's the typical feature of the atelectasis. With this, I think we can conclude today. We'll discuss about cavities in the coming classes, cavities and other regions. If there are any questions, I'll try to answer the question and then we'll conclude today. No questions. Right. Okay, we'll conclude today. Thank you.
Thank you, sir.